Well, good morning, ladies and gentlemen, and I'm delighted to be able to join this meeting. And the symposium title is Prevention of Recurrent Viral Respiratory Tract Infections and Complications. Can we fill the therapeutic void? And we have three speakers today. Both my co-speakers are esteemed in their fields. Deborah Strickland is well known to people in the immunology and respiratory disease field and allergy. And Philip is a well-known pediatric pulmonologist with a great research experience. And they'll be talking on immunological factors related to the development of the immune system, as well as the some of the evidence about microbial-driven early interventions. This is a very important subject. For the last 50 years, there's been very little advance made in asthma treatments for reasons which are probably not that clear, but I think if you think about it, why haven't monoclonal antibody treatments and biologics taken over the field? And it's probably because there's so many parts of the immune system that are involved in allergy and asthma that it's going to be very difficult to find any one pathway which is going to solve the problem. So today we're going to be talking about the possibility of augmenting immune system responses using a general stimulant, which we'll be talking about later. And I think this is a very important topic, and we're very pleased that PHARMA has been able to get this seminar running, because it's a topic, I think, which needs much more discussion, and it's an area of research which is very interesting. So I'd like to introduce the first speaker to you. That's Deborah Strickland. She's the research focus area head for earlier development at the Telethon Kids Institute and the team leader in experimental immunology. She's also an adjunct professor associate professor at UWA. She completed her PhD at UWA on regulation of immune homeostatic responses in the respiratory tract. She's also won prestigious awards in her time and has established a research program to look at pathogenic mechanisms associated with early risks of asthma, and also how the mother's immune system can interact with the child's immune system and the environment. So I'd like to introduce her, and she'll be talking about understanding the role of the immune system and the host microbiota in the development of pediatric chronic respiratory conditions. Thanks, Deborah.
Hi, I'm just share my screen now. Right, it's great to be here and participating in this session, and I hope everybody enjoys it. The topic of my talk is immune modulation. Is it a strategy to improve early life immune system functions? I have a potential conflict of interest to disclose. I have had some supplemental funding from PHARMA for preclinical studies and gratis supply of OM85 for a clinical study on PAC and our preclinical studies. What I hope to do in this talk is provide a very broad overview of how I view immune modulation and its potential use as a strategy to prevent disease in early life. Now, we're all very familiar with the developmental origins of health and disease, which tells us that the environment, together with our genes, intersect mostly across early life due to the developmental plasticity at this stage of life to program our developmental trajectories and impact our risk for disease. Now, these environmental signals can be positive, beneficial signals, or they can also be detrimental signals. Now, my particular interest is in the immune system, and these environmental cues can modify cell function, and they also modify the microbiome. And we know that microbes are actually master regulators of immunity. Dysregulated immunity predicts, or actually influences the development of chronic diseases later in life. Now, the hygiene hypothesis reminds us that in the latest iteration, there are missing pieces to our environments, and it's actually an imbalance in signals during early life that programs dysregulated development. Now, as I said, the environment also supplies beneficial signals, and I guess one of the great examples of this is the story of asthma and traditional farming environments. And this work was done by Erika von Mudius and colleagues. And what this showed was that in traditional farming environments, exposure of the pregnant mother and the infant provide profound protection in children against allergic asthma, early infections, other allergic diseases, including rhinitis and atopy in general, and the protection is mediated by exposure to microbial compounds. And what's been found is that this is due to microbes in the barn dust, and the exposure is respiratory, and also unpasteurized milk through gastrointestinal exposures. These exposures modulate innate immunity and provide enhanced regulation of immune system function. These studies have also been replicated in multiple locations in the US and across Europe. It's important to note, however, that not all farming environments are the same, and the protective effect of being raised was ascribed to distinct exposures. Now, what are the broad mechanisms associated with this farm effect and protection against disease? Overall, it's the activation of innate pathways that equip the infant with capacity to appropriately shape and respond to inflammatory challenges. In cord blood, there's been found to be enhanced neonatal DC maturity, enhanced capacity for interferon productions, and increased Treg numbers. In children, what's been observed is accelerated postnatal functional maturation of immunity, enhanced regulation of the intensity of inflammatory responses, which is important in early life because exaggerated pro-inflammatory responses are at the base of many severe diseases. There's also a shift from Th1 bias to Th2, and that comes along with IRF7 dependent capacity. And there's increased Tregs as well as their functional capacity. So this work has also been taken to animal models using barn dust from, in particular, Amish farms. The process has been found to be TLR dependent, which is very important. And this is through maternal exposures, regulated development of immunity, attenuated microbial sensing in the placenta versus enhanced microbial sensing in peripheral tissues. This has also been associated with clear innate immune signaling pathways and evidence of epigenetic changes. Another interesting point is that it's not just the immune cells per se that are affected, and there's been shown to be a lot of effect on other cells, including epithelial cells. So what are the major risk factors for developing asthma? Severe early life lower respiratory viral infections. There's a window of opportunity whereby the number of respiratory infections is much higher during early life, and the types of viruses and how they act will be discussed later in this session by the other speakers. What's important to note is that it is the number of lower respiratory tract infections, the severity of them, wheezing associated with these, and febrile disease that increases the risk for developing asthma. Atopic sensitization has also been recognized as a risk factor. And here we see that the number of LRIs predicts the probability of wheeze at 5 years. And there's also an impact of atopic sensitization. And this is greater at actually lower numbers of respiratory tract infections. So why is early life? Why is this window of susceptibility here? Well, there are two things that early life respiratory viruses do. The lungs are still developing, and we can imagine that there's a lot of damage and tissue remodeling happening to the tissue, which is also a risk factor for developing respiratory diseases. The immune system during early life is also immature, and there's a very slow postnatal maturation. The Th2 predisposition and deficient interferon capacity are all related to the increased susceptibility for asthma, for respiratory viral infections in early life. There are also some very recent new learnings that are important and I think worthwhile mentioning as drivers of severe lower respiratory viral infections during infancy. The first one, in a study done by Anya in our lab in Perth, demonstrated that infant susceptibility to severe LRI is associated with exaggerated expression of type 1 and 3 interferons, demonstrating a lack of regulation of inflammatory responses. And this is shown here. What you need to remember is that in terms of immune activation, the exaggerated responses are associated with much more severe impact on health. Number two, there's also now known contribution of bacterial pathogens to the severity of viral-associated LRIs. This is a study done in the CAS birth cohort, CAS being a birth cohort from Perth. And this has demonstrated that the infant nasopharyngeal microbiome can impact the severity of lower respiratory infections. In a healthy microbiome, there's a series of standard bacteria. These particular bacteria here, when they're present, they enhance the risk for viral infections to move from upper respiratory to lower respiratory and increase the risk. There's also evidence now that baseline neutrophilia is associated with more severe disease. So what's the rationale for asthma prevention that we're currently working with? As lower respiratory viral infections are a major risk factor during early life, if we could simply reduce the incidence or severity, this should have an impact and reduced asthma rates. Quite simple in its essence. This is not only important for asthma, lower respiratory infections remain a leading cause of death in children under 5 years of age. So it has very broad importance. Now, immune modulation as a preventative strategy has been empirically used for centuries. This is not a new thing, but it's becoming more and more important. Basically, I'm going to talk about microbial-based therapeutics. Many have been tried, including lactobacillus, flagellin, endotoxins, strep bacteria therapy, and probiotics. Across the literature, there is not yet convincing evidence that any of these have an overwhelming impact on incidence or severity of LRIs. Bacteriolysates, on the other hand, are the one that provide the most compelling evidence. There are a few bacteriolysates that provide good evidence. MV130 has recently been described in a study by Nitio et al., where MV30 has been used in a randomized double-blind placebo-controlled trial and prevents recurrent wheezing in children. MV130 has also been shown to impact airway epithelial cell function and interesting mesenchymal stem cells, which play an important role in tissue homeostasis. What I'm going to talk about mostly is the immune modulating agent OM85. Now, OM85 is made up of 8 major species of bacteria, gram-positive and gram-negative, 21 strains in all. It's mostly delivered orally, and it has been used across a very wide range of ages and also in immune-compromised patients, and has an extensive safety profile. There's evidence that it protects against viral and bacterial infections and decreases the frequency of infections, the inflammation severity, the duration, the febrile time, cough, wheeze, and the use of antibiotics. There's also been a notable enhanced effect in younger children with higher number of RTIs in the previous year. And there are a number of clinical trials that are underway and have been done with OM85. And I won't talk much about these, but this will be addressed in other talks during this session. What I want to talk about is how it works. Now, OM85 is mostly delivered orally. And the theory is that it affects gut immune cells, and there's evidence for maturation of mucosal DCs in the Peyer's patches, enhanced Tregs in the gut, and it's thought that via mucosal homing activities that cells migrate from the lung to from the gut to the lung to provide beneficial impact on lung immunity. There are a series of known effects of OM85 on immune system function, summarized here. Affects a large number of innate cells and their functions. Dendritic cells, their antiviral cytokine production is enhanced, inflammasomes decreased. It also impacts epithelial cells. Many studies report increased numbers of Tregs and activation of the Tregs, polarizing of a Th1 response. B cells are also impacted in their antibody production and can activate monocytes. What I want to talk about is OMPAC. Now, this is the first study that's been done in infants at high risk for asthma development. And this was published in JACI, the clinical component was published in JACI in 2019. It's a phase 2 double-blind randomized placebo-controlled trial in infants aged 3 to 9 months at high risk for asthma based on parental history. The clinical outcomes were that OM85 was safe to use. The study unfortunately was underpowered and we were unable to stratify for severe LRIs. However, there were 3 major findings. The time to first LRI was significantly reduced. There was a reduction in the severity. The cumulative frequency of SRLIs was greater in the placebo group. And through the study period, children in the placebo group had more days had more days of SLRIs than those randomized to the OM85 group, demonstrating significant protection against SLRIs. During this study, we collected blood after the first winter treatment and did some immunological analyses to try and determine underlying mechanisms. From the we isolated PBMCs from the blood collection, and we did cellular profiling, molecular profiling, and some in vitro culture work, stimulating with LPS and poly-IC as a mimic for both bacterial and viral responses. Here, I'm going to just summarize our findings. The OM85 group had a much more complex gene network, with many more genes being upregulated. OM85 in particular activates type 1 interferons. OM85 dampens pro-inflammatory modules. In the OM85 group, the the pro-inflammatory module was much smaller. And the reason for this was because, And the reason for this was because part of the pro-inflammatory module was placed into another module. So OM85 in particular reprograms TNF signaling such that TNF is now contained within an additional small module and is not expressed together with the type 1 interferons. In this way, we can control pro-inflammatory responses and still have adequate pathogen control responses. OM85 also rewires IRF7 in response to LPS. The enriched pathways analysis suggested increased pathogen sensing and decreased inflammation in OM85. We also demonstrated that OM85 boosts proportion of circulating Tregs. This data is currently under revision, And so I'm sharing this with you early. So in summary, in the OMPAC study, omega-5 treatment protects high-risk infants from LSRI by mildly boosting type 1 interferon responses to LPS via IRF7, dampens inflammatory responses to LPS, and increases circulating Treg proportions. In this way, the conclusion we drew was that OM85 programs the antibacterial arm of the immune response to protect against SLRI. As a summary capsule statement from all the work that exists with OM85, the way I view it is that OM85 modulates innate immunity. It controls pro-inflammatory immune responses without constraining the interferon networks that are central to first-line antimicrobial defense. And along with this is the parallel induction of immune regulatory pathways and a more balanced immune responsiveness, which is very important during early life. There needs to be further mechanistic understanding. We don't know if there are any gender effects. And there's also needs to be more discovered in terms of the potential to activate other cell types. This is important because if it activates mesenchymal stem cells or epithelial cells, we might want to reconsider what treatment route would be the most beneficial. Now, both the farming effect and OM85 run parallel to a recently emerging paradigm, innate immune training. Now, innate immune training describes that the innate system has memory, and that following a first challenge, a second challenge to an unrelated pathogen can be enhanced for functional immune competence. Now, this is via programming of prototypical cells of the innate immune system, such as NK cells, monocytes, macrophages, DCs, ILC2s. Now, the large majority of studies in innate immune training have been done with beta-glucan and BCG vaccine. And as a summary of the findings, BCG and beta-glucan induce central trained immunity. And now this is in the bone marrow, where the effects are seen on innate progenitors. There's enhanced myelopoiesis, a functional reprogramming of innate progenitors. These occur via epigenetic mechanisms. There's also metabolic and transcriptomic reprogramming of these innate progenitor cells with long-term changes. There's also effects in the periphery, demonstrated to be acting on epithelial cells as well. The main finding is that BCG and beta-glucan can enhance pro-inflammatory responses to a second challenge of an unrelated pathogen. So how do we consider OM85 versus the farm effect versus innate immune training agents in terms of prevention of early life lower respiratory viral infections? OM85 and the farm effect both target innate immune system. They both deliver enhanced maturation and immune competence and enhanced control of pro-inflammatory responses while maintaining effective pathogen clearance. This results in balanced immune responsiveness. There's evidence of epigenetic changes. There's not yet much information of reprogramming, but we'll come to that in just a minute. The classical innate immune training agents also target the innate immune system. They induce enhanced pro-inflammatory responses to unrelated pathogens, and this involves programming at the metabolic and transcriptional level and epigenetics. What's not clear is whether classical innate immune training agents also invoke a regulatory arm. And so in terms of immune modulation, the context and the timing of different treatments is going to be a very important consideration, as during early life, exaggerated responses cause the most severe disease. I'd just like to take a step to the side now and go back to the beginning and remind you that the period of highest impact of environmental signals on immune developmental trajectories happens during pregnancy. Maternal immune activation is known to program dysregulated immune development in the developing fetus. The problem with this is that pregnancy is also a Th2 biased environment and has very heightened susceptibility to exaggerated inflammatory responses. Now, these inflammatory responses are responsible for preterm birth and fetal growth restriction, which impacts the state of the lung when it's first, when the child is first born, and this in itself has a big impact on the development of lung diseases. There's also increased mortality and morbidity associated with infections during pregnancy. We've done a whole lot of work in our lab looking at whether or not OM85 would be a suitable option to take to the pregnancy area. Simply, we've used mice, treated pregnant mice with OM85 orally, and we've either given the pregnant mums influenza or LPS and looked at the responses, or we've let the pups be born and used neonatal models to look at the impact of OM85 on neonatal immunity. The first one I'll briefly discuss is the maternal influenza infection. When we treat the mother with OM85 and give influenza infection, there's normally a serious disease without OM, and with OM, the clinical score of the pregnant mother is significantly reduced. Fetal weights are preserved, and birth weight of the offspring are preserved. Now, this is associated with stabilization at the gestational tissue level in terms of homeostasis and integrity. DCs don't leave the uterus, and you'd get fewer inflammatory cytokines. What about when we give mum LPS? When pre-treated with OM85, LPS preserves, after LPS, the fetal weights are preserved. Survival of the pups increases. And again, the inflammatory cytokine response is reduced, and normalization of homeostatic mechanisms operating at the gestational fetal-maternal interface. Transcriptional analyses of these showed that when mums were pre-treated with OM85, there were only 2 modules that remained. And effectively, what this tells us is that normally with LPS, in untreated, there's an induction of a huge pro-inflammatory pathway signature and primary inflammatory defenses. In the case of treating with OM85, this regulates the pro-inflammatory response and maintains the primary innate immune defense response. What about when we let the pups be born? We've also performed prevention of asthma studies in the offspring and show that when the mothers have been pre-treated with OM85, the offspring are protected against the development of an asthma-like disease. There's reduced airways hyperresponsiveness, reduced total BAL inflammation, enhanced Tregs, and changes in DC populations that normalize the inflammatory response. What we've associated this with is a shift in the bone marrow progenitor cells. The fetal bone marrow transcriptomic response showed us that the drivers of following OM85 treatment were XPP1. Now, this is very important because XPP1 is crucial to DC survival in the lungs. What we get from this is an overview of how OM85 might be working when we treat pregnant mums. OM85 is impacting our DC progenitors in the bone marrow. It gives us enhanced myelopoiesis. It functionally programs our DC progenitors, and this is via metabolic and transcriptional pathways, and upregulates XBP1. What this does is to increase myeloid seeding and maturation in the airways, such that when the animals were born, they had enhanced immune competence due to the accelerated postnatal development of immunity. This is just a graph here demonstrating within the bone marrow the increase in all of the myeloid progenitor populations. We also used a model whereby we gave the neonatal mice a severe respiratory viral infection. In this case, we used a murine mimic for RV. Now, we had to titrate the model down. Adults usually receive a dose of 10 to the 6, and for this particular study, neonate survival sits at about 75% when we use 2 log lower. When we pre-treat the mums and give the pups the virus at 2 days of age, we go from 75% survival up to 100% survival. This is associated with reduced weight loss, change in viral titers, enhanced IL-1 expression. Sorry. So in terms of transplacental immune modulation with maternal OM85 treatment in our preclinical work, we observe benefits for mum. We protect maternal health. We regulate inflammatory responses, maintain gestational tissue homeostasis, and preserve fetal health and development. It also impacts the fetus, targets bone marrow myeloid precursor compartment, enhances XBP1 as a putative driver, accelerates the functional maturation of CDCs, and enhances their immunocompetence and regulation of inflammatory responses. In the infant, we see enhanced myelopoiesis in infant lung. Functional immune competence of DCs is improved. There's enhanced immune regulation, balanced immune responses. We see reduced susceptibility to early life viral infections, reduced susceptibility to asthma. So the concluding comments I have is that OM85 in particular, as well as MV130, it's very safe. It's effective in prevention against LRTIs. Programs the innate immune system to deliver a balanced immune response. There's also a potential broad application to control infection, inflammation in other diseases, and the potential to program diverse cell types. So the considerations that might be important for the future: we clearly need further mechanistic understanding. Treatment route needs to be investigated. Is there any gender effect? The timing of the treatment will be very important. And also understanding the appropriateness of diverse immune modulating agents and when they should be used. Thank you very much for listening. And if you have any questions, if you could pop them into the question box, that would be great.
Thanks very much, Deborah. And just to reinforce that point, there's the Q&A button. And if you've got any questions for the Q&A section of the seminar, then please put them in there and we will respond to them. We will be taking questions in that sense, in that forum at the end of the talks. And thank you very much for that comprehensive talk on the immune system and its responses, Deborah. The next talk is from Philip Latson, and Philip is the head of pediatric pulmonology at the University of Bern Children's Hospital in Bern in Switzerland. He studied medicine at the University of Munich and started training there as a pediatrician, but continued his training in research at the University Hospital of Bern. He completed a PhD in epidemiology and respiratory physiology in 2008, and by 2016 he was appointed to his current position. His major research interests are developmental physiology of children with or without lung disease and the role of environmental pollutants. Innovative and non-invasive lung function tests are also one of his interests, and he's received many prestigious awards, including the Klosterfrau Award in 2009, and he supports PhD students and medical students. Philip, welcome. His talk will be on microbial-derived early intervention in recurrent RTIs and complications in innovative approach. Thanks, Philip.
Thank you, Peter, for the kind introduction. Good morning, afternoon, or evening, depending on where you are. I'm happy to give you now a change from preclinical to clinical application of OM85 and give you an overview on clinical studies and early intervention on recurrent RTIs. My conflict of interest is shown here. I especially would like to point out that I receive a honorarium for this talk from PHARMA. I will first give you a short overview on definition, epidemiology, and pathophysiology of RTIs and recurrent RTIs. And then I'll show single studies and systematic reviews that summarize the evidence on microbial-derived early intervention. And in the end, I would like to point out some unknown points and give you a short outlook. Respiratory tract infections. You all know that they are very common in children, especially in young children, and they are usually caused by viruses. And if you have in your practice or in your own child, if you have a child with a respiratory tract infection, it's rather easy to differentiate clinically whether this is an upper or lower respiratory tract infection, and then also if this is accompanied by wheezing symptoms or not. However, in epidemiological studies, it's less easy because often data is obtained retrospectively by chart review, and usually mothers do not have a stethoscope and can easily distinguish between wheeze and no wheeze. And as German native speaker, I would also like to point out that language use in questionnaires of different countries and publications might further complicate matters. For example, bronchiolitis sometimes is used as a synonym for wheezing episodes. In other countries, like German-speaking countries, bronchiolitis is only used in combination with RSV infection and not necessarily accompanied by wheeze. And this is just one example what you should consider when reading and interpreting these studies. And of course, as all of you know, as doctors or parents, prevalence and underlying viruses differ enormously between age groups. And these points need to be considered when you read the studies, and especially when you think about translating these results into your daily clinical routine. I will now, for simplicity in the talk, differentiate between RTIs in general, then specifically focus on wheezing episodes and asthma exacerbations, because these are three different things in my opinion. First, a short overview on the underlying reasons for RTIs in infants and children, and I would like to give you here a nice show you a nice schematic drawing from an excellent review article on bronchiolitis and wheezing in early life, showing the frequency of different viral agents in hospitalized children for either bronchiolitis or wheezing. And you can see that in the first year of life, here is given the age, RSV is by far the most common virus leading to hospitalization in these children. Rhinovirus the second, then taking over from around age 1 to be the most prevalent reason for hospitalization. Other viruses like Boca virus, human metapneumovirus are less common, but also occur. How does it look like if you go into non-hospitalized children? And this is data from Australia from a community-based birth cohort. They examined or followed 263 infants throughout the whole first year of life. Nasal swabs were taken at every respiratory tract infections, and data here are derived from almost 1,000 episodes of ARIs. And you can see now here the different pathogens and the percentage as they were found in the respiratory tract infections. The authors also differentiate between, in light gray, upper respiratory tract infections, dark lower respiratory tract infections, and dark gray lower respiratory tract infections and wheezing. And you can see here that the picture is very different compared to the hospitalized children, with rhinovirus being the most prominent virus, almost 50% for upper respiratory tract infections, and RSV only being responsible for about 10% of these respiratory tract infections. However, you also see here that the more severe infections are low respiratory tract infections and additional wheezing, the proportion of RSV increases relatively. And the same picture as for the hospitalized patients, other viruses occur but are less common. We somewhat confirmed these findings in our Bernese cohort. Is less infants, 112 infants that were followed in the first year of life. Nicolas Rigamet did this some time ago. And we also took a nasal swab at the first respiratory tract infection and also found that rhinovirus is the most common in 23% of the samples. However, coronavirus, parainfluenza virus, and RSV were relatively more common compared to Australia in our cohort. So the picture changes a bit depending on where you are geographically, and different other factors also play a role. How does it look like now if you do not assess infants when they have symptoms, but if you look into which viruses occur in general, even without symptoms? And this is data that was also obtained within this BUILD cohort, the Bernese infant lung development cohort, where we followed 32 healthy infants for the first year of life. We performed every second week a nasal swab and weekly telephone interviews to assess symptoms. Out of these 32 infants over the first year of life, we were able to assess viruses in more than 700 high quality swabs. And almost half of these swabs were positive for a virus, 44%. And approximately half of these were accompanied by symptoms. The other half was not accompanied by symptoms. So infants were without symptoms, but also had a virus detected in the nasal swab. And here you can see that what you would expect, rhinitis is more common and upper respiratory tract infection more common than lower respiratory tract infection. And here the picture again is a little different. Rhinovirus is now was found in 1/4 of all swabs, and the other viruses, coronavirus, adenovirus, and so on, were less common. And especially, I would like to point out that RSV seems to really make symptoms because it's even less common when you swab asymptomatic infants. So that's just to show you that it's not every virus makes symptoms. We then thought, okay, maybe it's the type of the rhinovirus that leads to symptoms. It's known that certain rhinovirus types are associated with more symptoms, more severe symptoms, and Peter will talk about this later a little bit. And we genotyped the rhinoviruses that we found in these 20 infants here in a smaller sample. I will enlarge this in order to enable you to fully appreciate results. And this is an infant followed every week. And whenever there's a sign here, we found a rhinovirus and then we genotyped it. And the legend here explains you whether it's a type A, B, C, and then the number of the type in numbers. And if you have a symbol like that one, there were no symptoms. If the line also goes above here, there were symptoms, and if there's a star in addition, there were also wheezing. And the picture is very heterogeneous. In this child, for example, we found a rhinovirus B104, no symptoms, then a C24, no symptoms, C39, no symptoms, then C21 symptoms, A15 symptoms, and so on. In this one here, we found twice a B6, first week accompanied by symptoms, and then second one. And then the 4 weeks in a row, the A89 with 2 weeks symptoms and 2 weeks not. So you can see it's really very many different heterogeneous picture, many different genotypes, and we could not draw any firm conclusion based on the small sample size here. And it changes a lot, I would say. That leads me, this was just the background, because I think it's important to understand what are the causes of respiratory tract infections if we then go into intervention to see that the number, duration, and so on is reduced. So I will now talk about the microbial-derived early intervention with OM85 and show first results from systematic reviews and then present you some single studies. So this is a busy slide. I'll try to guide you through. This is a Cochrane review from 2012, where they compared any immunostimulant with placebo for preventing respiratory tract infection in children. They included only children, outpatient setting, any intervention in immunostimulant, and comparison is placebo. Here are the different outcomes that they assessed, and here given is the risk or the reduced risk. And they show that it's the number of acute respiratory tract infections is reduced by factor 1.24 with this confidence interval when OM85 is given. This results out of 35 studies with more than 4,000 children included, and the quality of the evidence is moderate. They also comment that the effect depends on the number of RTIs in the control group. And this relates to a risk reduction of almost 40% in the intervention group. Side effects of adverse events were not very common. 21 per 1,000 gastrointestinal in the placebo groups and 30 per 1,000 in the intervention group, and skin 3 per 1,000 versus 7 per 1,000. These results were then confirmed in a later meta-analysis. The authors included 53 randomized controlled trials. I'll try, sorry, I cannot. Okay, here. I try to show you now what the authors did here. They included these trials. They always show the mean number of respiratory tract infections for the OM85 group, and then the mean number here for the control group, with the mean difference given here and the confidence, 95% confidence interval, and they show it also in this typical graph where you find the effect size with the confidence interval, and if the confidence interval doesn't include the 0 line, it means it favors OM85, as you can see down here, with the effect. If it includes, it's not significant, and if it had been on the other side, it favors control. As you can see nicely here already in the graph, there's clear evidence that overall OM85 has an effect with a mean effect size of 2.33. So it means that in the intervention group, the number of respiratory tract infections is reduced by 2.33 compared to the control group, and highly significant, of course. This is based on 4,800 children. And the authors then also showed only RCTs that assess the duration of wheezing. And interestingly enough, this is now here 8 RCTs with more than 700 children. the same plot again. Interestingly enough, for wheezing, duration of wheezing, the effect size is even higher, and the number of days with wheezing was reduced by 3.3 days, which I think is quite enormous, actually. And this was in 2021 confirmed in another systematic review and meta-analysis. They were a bit more strict with the inclusion criteria, so they only included 14 RCTs with 1,800 children, but because of the date, some newer trials. But in the end, the picture is comparable, little less strong effect in this meta-analysis, but still highly significant. How does it look like now for wheezing and asthma exacerbation separately? And this again is a different meta-analysis and systematic review. And you can see nicely if you compare these two graphs here for wheezing episodes, the upper one, and asthma exacerbations, the lower one, that the effect size again is much higher for wheezing episodes than for asthma exacerbations, as we have seen before, wheezing versus RTIs. So now I'll show you some single studies for several reasons. I picked certain studies and will explain to you why. So this is a rather new study from Italy, from Milano, a randomized placebo-controlled double-blind phase 4 trial. They included children between 1 and 6 years with a mean age of 3.6 years. They had to have at least 6 documented episodes of RTIs in the previous year, which I think is quite a lot actually. And this here is the treatment group, and this is the placebo group. And you can see that for any respiratory tract infections, there's a clear reduction in the occurrence, 33% versus 65% for the treatment group. And this is true also for acute otitis media, 24% in the treatment group versus 45% in the placebo group. And antibiotic prescription. If you separate the different infections, it's again, not surprisingly, respiratory tract infections. There's a clear picture. No influence on bacterial pharyngitis, otorrhea, or in this case also wheezing. But I would like to mention that they also looked into days of absence from daycare, and for some of us important working days lost by parents, there was also a clear effect for both socioeconomic factors or outcomes. In this study, the PHARMA study, Deborah has shown before. I would just like to emphasize certain things. That's why I included the slide as well. Deborah nicely showed that these are at-risk infants. I would like to emphasize that these infants were 3 to 9 months at recruitment, that's why it's been a phase 2 trial, because it's approved only from the age of 6 months on in most countries. And then the treatment period also was not the usual 3 months, 10 days per month, but was 5 months during winter for 2 seasons. And the results have been shown before, but I think it's even though the study was underpowered, officially you can see that there's a clear effect also in these young infants that did not have to have a history of recurrent wheezing compared to the other study. And the last trial I would like to show you results for is the trial from Razi et al. That was published in the Yaki in 2010. It's from Turkey. It's a randomized placebo-controlled clinical trial. They included 80 children with recurrent wheezing and followed them for 12 months. And you see here the cumulative number of acute respiratory tract infections for the OM85 and the placebo group in the different treatment periods. There's a clear difference, mean difference between 2.8 in placebo, 2.2 in the OM85. So the mean difference minus 0.62. That increases by increasing follow-up time and also leads to an increased cumulative difference between the two groups. And if you now look into wheezing episodes, it's the same study, just a different display. The same happens here, just the effect size is a little bit higher, as we have seen it before from this meta-analysis. there's a clear reduction in the cumulative number of wheezing episodes per patient, between 30% for the first 3 months and then 38% for 12 months follow-up time. So this will now lead to the unknown points and outlook. I personally believe it's still a little bit unclear what is the best target population. Results indicate that the more severe the history of previous infections, the higher the effect size. But some data also suggest that even all children could benefit. So that's not clear, or something in between. I don't know. What is the best age to start with prevention intervention? Maybe it's pregnancy, as Deborah suggested. Which of the underlying mechanisms are the most important? And I believe this is still not entirely clear, despite a nice talk from Deborah. And I think it might be important also if you look into the pattern of virus infections. Do we cover all viruses with our inflammatory, anti-inflammatory mechanisms, or are there certain viruses or effects upon viral infections that are better covered than others? And then, of course, this is probably unknown now, but we'll know more in next years. Does the change on the usual pattern of viral infections? I mean, all over the world, there was almost no RSV in winter, but there was a delayed RSV season 5-6 months later due to COVID-19 pandemic restrictions. Does this influence the effect of the intervention? And I believe, as an outlook, that upcoming larger RCTs, Peter will talk about this, involving children with varying severities, will allow more specific indication in the future. And a better understanding of the exact underlying mechanisms, best windows of opportunity, will help to determine the best starting age for the intervention. With this, I like to conclude that there is good evidence for microbial-derived intervention with OM85 in recurrent RTIs, wheeze, and asthma exacerbations. The effect size depends upon the underlying pathophysiology and seems to be higher for children with more symptoms. Thank you very much.
Thanks very much, Philip, for a very comprehensive review of quite extensive clinical data. I'll be now talking, and my topic is upcoming respiratory results and future implications in clinical practice. So a lot of the groundwork of understanding what's happening in immunomodulation has been explained extremely well, I think, by Deborah and Philip. And I'm going to cover very small parts of that, and then talk about, I'm going to talk about some of our work, which is related to the viruses involved in wheezing, and some of the new insights we've got from that, from very recent data. I'm going to point out maybe how anti-IG might work, then reinforce what Deborah is saying about the importance of interferons in wheezing children, and then Philip's already summarized the immunomodulation rationale and studies, so I'll pass through that very quickly, and then talk about the 4 large randomized controlled trial studies that are currently underway, and will give us a lot of information about what's happening with immunomodulation in various scenarios. So I have declarations of disclosures of interest, which for PHARMA and also for AstraZeneca, we've received assistance for them for some studies, and honoraria and consultancy fees from AstraZeneca and PHARMA. So this is work which we've just had published through, it's just being accepted and will be published very shortly in the Pediatric Infectious Disease Journal. And what we did here was use the Maverick platform. The Maverick study has been running for 15 years. We've now recruited just under, I think it's 980 children between the age of 0 and 16 years of age, those presenting with respiratory tract infections, particularly those with wheeze, to our emergency department in our teaching hospital, which was Princess Margaret and is now Perth Children's Hospital. The aim of the study was to understand the mechanisms of acute viral respiratory infections in children, which is where that acronym comes from. And we have taken a great interest in viruses, as we realized soon after we started using this platform that viruses were the main generators of acute exacerbations. In 2006, when rhinovirus C was discovered, we collaborated with Jim Gurn's group in Wisconsin to study the effects of rhinovirus C versus other viruses. Bear in mind that the Maverick study looks at children who are at the more severe end of wheezing, that is, that with moderate to severe episodes presenting to a teaching hospital, and the majority of them being admitted. So they're quite different from the ones you see in the community. Nonetheless, for this population, they're the ones that cause us a lot of trouble. They're the things, the exacerbations are the things that we want to prevent. And the bulk of the morbidity from virus infections and from the problems that are caused by hospital admission come in this sort of group. And they're the things we're trying to avoid. So in this population here, we now look at age group versus which virus is infectious, and very similar to studies before, rhinovirus is occurring a little later, and RSV is the predominant virus in the first 6 months and year of life, very much so. As Philip pointed out, though, in the community, rhinovirus is more common than RSV in terms of wheezing episodes in the first year of life. But as severe problems go, RSV in hospital admissions is very much the most important. But interestingly, it dwindles down and virtually disappears by the middle of the first decade. Around the 1 to 2 years of age, rhinovirus species C starts taking over as the major virus causing wheezing episodes in children. And you can see that it's the p-values here, that it stays very strongly positive and high for right throughout the preschool years, up to about 6 or 7 years of age, when it starts falling quite quickly. And for children over the age of 10 years, most viruses are contributing a small amount, but there's no dominant virus at that stage causing wheeze. So we've thought that we should call this the preschool severe wheezing virus, because it's so dominant, and other studies have shown exactly what we have, that in children presenting to or admitted to hospital with wheeze, rhinovirus species C is the dominant virus. And if you look at the data, you can see in other people's data, this age factor here is quite the dominant one. We've also done a study in Morocco with Kike Bassat and others, showing much the same age group there. So because asthma and wheezing disease declines so exponentially with age, this is a study we've done in our department showing, our ED department showing 36,000 ED presentations over 10 years, that there's a very rapid decline in wheeze presentations. So the two viruses, RSV and rhinovirus species C, dominate in this period, and the majority of the infections that are caused by, that cause admissions to hospital are these two viruses, because after that, admissions to hospital become much less common. So RVC is very much the preschool severe wheezing virus, and here you can see by amalgamating those two sets of data that RSV dominates early, but after that, rhinovirus C makes a very large contribution to hospital admissions. In fact, if you look at it another way, rhinovirus species C is probably the most common virus causing admission to hospital for children in Western society. It's a little different in other places, and I won't go into that now in detail. So the data that I want to show you now is work which was done by a medical student from the Netherlands, Sarah Lutz, who's actually got dual nationality, and she came to Australia to do her research project doing her medical degree training, and this was her thesis, and it's now being prepared for publication. But I thought I'd share it with you because it's quite different from what we'd expected to see. What we gave Sarah the task to do during her stay in Western Australia was to look at the relationships between IgE and specific virus infections. And we had nearly 700 at that stage. And Sarah's analysis shows quite clearly that rhinovirus C is associated with the highest levels of IgE. And that's true for total and specific IgEs. In contrast, other viruses, RVA is a little bit elevated, but is certainly a lot less so than rhinovirus species C. And RSV is actually quite low and not particularly different from control group. So here we have a situation where one virus is associated with high IgE levels, and they're persistent because at the end of the recovery period, about 6 weeks later, when we've looked at it in children, I won't show you that slide now, but the level of IgE is still very high. So it appears that one virus is picking out the children with high levels of IgE, and those almost certainly are the children with the greatest levels of atopy. It's made us rethink the relationship between allergy, atopy, IgE, and wheeze. It does appear that certainly in children presenting to or admitted to hospital, that rhinovirus C is the virus that is producing that relationship. It doesn't have a lot to do, I would think, with allergy, because it's not like there's an allergic response to viruses, and protection for viruses is not coming from that part of the immune system. So it seems like the rhinovirus C is exploiting children who've got high IgE levels and getting in and causing problems. As we know from our original study and several studies since, rhinovirus C actually causes more severe clinical status for wheeze and asthma in children who are presenting to hospital. So again, it's very different from in the community, where rhinovirus C is much like Philip was saying, where RSV is not a very dominant virus infection in the community, but it is in hospital presentations and admissions. Rhinovirus species C is very similar to that, in that it does much the same sort of thing. So we're now asking the question, how much of the relationship between allergy and Th2 and IgE that's associated with asthma or preschool wheeze, how much of that's actually due to this relationship with RVC? And if you took RVC away, would it still be there? The answer is, I think it would be, but much reduced. In this study, we've now just compared with controls, and I've already mentioned what we did there, so I'll pass by. So we also are interested in how anti-IgE works, because given that rhinovirus species C is seeking out children with high IgE levels, we wonder now whether the relationship for anti-IgE is coming through its ability to reduce IgE levels and therefore stop rhinovirus C, and probably other viruses too, exploiting high IgE levels. We don't know the mechanism. It may be by attacking cells that have IgE on their surface, on the surface receptors, and causing them to degranulate. But clearly in children with who are given anti-IgE omalizumab, we see reductions in rhinovirus infections, both prevalence and in viral shedding, and we see reductions in illness and in particularly in viral illnesses. So the question we're now asking is how much of that is related to one particular virus and others, and it's something we'll be pursuing in the near future. Next, interferons in wheezing children. Well, I think Deborah covered that so well, I don't need to discuss it much more, but I would like to mention a study that we've done. Clearly, as Deborah has very clearly shown, normal antiviral immunity in to RV, and other viruses, of course, is driven by interferon responses, and we know that these are reduced in children with asthma, as she's shown, and as other people have shown. Susan Prescott, Fernando Martinez's group, Seb Johnson's group, all have shown the relatively defective interferon responses, particularly for type 2 interferons, from birth right through life. That's this work here. This is Susan Prescott's work from using cord blood cells and PBMCs from and circulating immunoglobulins, interferon gamma from Fernando Martinez's study, and the study of induced infections from Seb Johnson. The work of Adnan Kustovich's group, published a few years ago, where they induced rhinovirus infection and looked using machine learning at the cytokine responses to work out what the phenotypes were related to and what were the cytokines that were most related to recurrent wheeze, and shown very clearly that the lowest levels of interferon were related to the highest levels of hospital admissions. In our study, we looked at antiviral wheeze, acute viral-induced wheeze in children, and in collaboration with Anthony Bosco and a large group of scientists, we discovered there were two distinct transcriptional patterns in nasal cells when we looked at transcriptomics. And there's interferon regulatory factor 7 high and low phenotypes, and that's shown here, where you can see that in this G5, which is this cluster here, the interferon releasing factor hub was the most dominant hub that we found in these children. We were comparing wheeze versus controls versus community cases, and you can see that there's a lot, the pattern across here in this heat map is very different for depending on which of those clinical groups it comes from. So what we showed also was that there was a relationship between IRF7 high and low and the lower risk of admission. If there were good interferon responses, the master regulator, there were low risk of admissions, less symptoms, less cough, less wheeze, and a longer duration before recurrence occurred. In contrast, those who had at the lower end of interferon IRF7 responses, or with a weaker hub, had a higher risk of admission and shorter recurrence. So we're getting some idea about what's happening now, but what about immunomodulation? Well, we've heard a lot about that, and I can just reiterate what Deborah said about Erika von Mutius's studies, which have been well known now, and also work that we've done in Southern Africa, in Mozambique, where we've been examining children with lower respiratory infections, and where asthma and allergy almost don't exist there. And we actually don't even have any coding for it, because it's not a diagnosis that's made in children presenting with acute respiratory symptoms in Mozambique. Pneumonia is much more common. There are, of course, as Philip says, many translation reasons why that could be the case. But we know for sure that asthma is much less common in developing countries and in farming communities. And so the idea is that that could be replicated by giving something like OM85, which is a mix of respiratory bacterial pathogens, and quite a lot of them, designed over 30 years ago for reasons that I think it might have escaped a bit into history now, but it's been around for a long time. It's used clinically in many different countries and is relied upon by general practitioners in quite a few countries to treat children who've got respiratory infections. And it appears that there's quite a lot of evidence, as you've already seen, for that. I'm not going to go over those points because I think Deborah's covered all of that so beautifully. And that's the study from Razi in Turkey, which again, Philip's covered. So I want to now just talk about the last aspect of my talk, which is the 4 studies that have come up to large and comprehensive randomized clinical controlled trials using placebo, currently underway. One of those is to really prevent the development of asthma, and that's the CIPPXX study, the oral bacterial extract for the prevention of wheezing, lower respiratory tract illnesses, and 3 other studies, the PHARMA study, which is our study, the BLIPA study, and the CIRCAN study, and I'll describe those in a bit of detail. I think these studies are going to largely define what we need to know about immunomodulation and its effect on wheeze and on prevention of wheeze. The CIPPXX study is the most expensive study ever funded by the NIH for asthma prevention and asthma treatment. 28 million US dollars, 10 sites, 822 subjects, and starting a few years ago and running through to 2025. It's going very well. Recruits come in at 6 to 18 months of age with at risk of asthma, and they're given the same treatment regime, which is common for most clinical trials for OM85, 10 days a month, but here now running out for the first 2 years of life with the aim of preventing wheezing LRIs in the 3rd to 7th year. A very, very important study. It doesn't have in its original makeup the mechanistic arm, but I would understand that the Tucson group and others involved will be adding to that. Very interesting study when it comes out. Our study is the POWER study, which is the prevention of OM85 wheezing exacerbation recurrence to get POWER. It's based on the MAVERICK platform, which I've already described, the mechanisms of acute viral respiratory infections in children, which has already got a lot of information on and has many aspects of systems biology in its examination profile. So the POWER study is based on that, and it is aimed at 200 subjects on preschool age and 60 controls in 2 sites. Peter Sly is running the site in Queensland, and we run the site in Perth. Those children presenting to the emergency department with acute wheeze, then after 6 weeks given OM85 in the same treatment pattern, but this time for 12 months with an aim of reducing exacerbations. But that wasn't the primary aim for doing the study. We really wanted to do a systems biology mechanistic study using the MAVERICK platform to understand what the immune system changes were and how they were induced by OM85. Our study is actually powered to be clinically effective, but really the main issue was to determine whether OM85, how OM85 changed the immune system response, and particularly IRF7 high and low. That study was held up by COVID last year. Even though we didn't have much COVID here, it was impossible to get other studies underway due to all the restrictions. And so we're now hoping to finish that by 2023. A further study that's being done using OM85 in a very large sense is the BLIPA study, bacterial lysis and preventing asthma in children with bronchiolitis. And these children recruits, it's a very large study, multi-center UK study with the chief investigator, Jonathan Grigg, and recruiting 3 to 12-month-old children. Those admitted with bronchiolitis will receive, again, OM85 in the same pattern as the POWER study, with an aim at reduction in wheeze in the future. It also has a mechanistic arm with Debbie Bogarts and her colleagues looking at systemic T-cell regulation and dendritic cell maturation. Again, an interesting study, and one which is going to take a few years, but will give us some very important answers. Finally, the CIRCAN study, which is the Children's Respiratory Research Collaboration of Australia and New Zealand, a study headed from a group from Geelong with 35 sites, over 2,000 subjects, a $2 million budget, and recruits the same age as the POWER study and the BLIP study. Oh, sorry, the ORBEX study, and with older children as well. Wheeze in the last 12 months, those who have been hospitalised or had 2 episodes needing bronchodilator. So these children will be a little less severe than the ones that we're looking at. The POWER study is aimed to look at children at the most severe end of the spectrum, those presenting to hospital with moderate or severe wheeze or asthma. This is more mild to moderate and will be given again in the same dosage duration. And the aim is simply to decrease exacerbation. So a very large clinical trial, which should answer a lot of questions about administration to preschool children. Unfortunately, they won't be looking at which viruses are related, but that could come later. So in summary, viruses are heavily involved in wheezing exacerbations, and the evidence now for more severe wheeze is that rhinovirus species C is not only deeply involved with that cohort, but also that it's picking on children uniquely with high levels of IgE. Again, I think work that needs to be replicated in other groups, but looks very strong to us. And we also know that anti-IgE works by knocking out circulating and IgE. So we wonder whether that's related to particular viruses. We know that interferons are important, and we'll be looking at interferon, the RF7 high-low feature in our study. And we've heard a lot about immunomodulation rationale studies, and I've now been able to tell you about 4 of the studies that are underway, 4 large studies that are going to take a few years, but will provide us with the answers we need to know. Does immunomodulation reduce respiratory problems, wheeze, and infections in children in a larger study? I suspect it would. You've already seen many studies showing a likelihood that it would be the case, but I think we need better studies for that. So now we're going to move to the Q&A session. And so far we have 1 question, and we're grateful for receiving that. Please send some questions in. We've got roughly 10 minutes left to have a discussion. Deborah, would you like to respond to that question? Just need to unmute.
Thank you. Yes, I think you covered that well in your talk, Peter. The most usual treatment regime is for 10 days a month. Various studies are using different durations of treatment. It's 1 capsule a day is the usual dose, and within that there's 3.5 mg of active ingredient. But whether or not that's an overkill still has to be determined. In fact, if there is reprogramming of bone marrow precursors, if that's the way that the mechanisms turn out to be, then it may be that treatment periods can be for shorter. Will still to be determined is how long the effects will last.
While we're waiting for another question, Deborah, I'll ask you a question. Bacterial lysates are being used, I guess, as a surrogate for environmental exposures. How good do you think they are for that? Is there any evidence that they actually are doing that?
As a surrogate? Well, I mean, we're talking about a mix of TLR ligands basically in a lysate. So it's a very broad spectrum, and whether or not actually parts of that would do the same thing, or whether you need multiple things to turn the right systems on, is something also. There might be something else that we learn that we can derive a new thing that's an even better stimulant, I think. But there is some evidence that using single entities does not work anywhere near as well. So the same with the farm environment, it's polymicrobial exposures that are giving the biggest impact. So milk and barn dust, which would include all kinds of microbial products.
Okay, and I think I'll ask Philip a question while we're still waiting for the audience. I think I'd ask the audience to ask the most stimulating questions you can. Philip,
I answered one of the questions by writing it down. Sorry, I might repeat it.
Do you want to share that with us?
Yeah, the question was, which are the number needed to treat with OM85 for respiratory tract infections and wheezing episodes? And I didn't know by heart, but I quickly looked it up, and there is a meta-analysis of Urs Schardt, 2010, published in the World Journal of Pediatrics, and this is the only paper I found, number needed to treat given, and he states it to be between 3.8, so roughly 4 for children with more than 2 RTIs and around 6 for children with 1 or 2 RTIs, which is rather low, I would say. If you have 4 children of your own, it's worthwhile to give it to them.
Philip, you showed in your talk that there's a great deal of evidence with p-values which are highly convincing, demonstrating efficacy of immunomodulation in reducing infections, and then you think that there's not enough evidence, and I'm not disputing that, but why do you think that that's not convincing enough?
I mean, I can tell you, whenever during our medical studies, bronchiovaxum is licensed, approved, and given in Switzerland, Germany, and so on for 40, 50 years. We always thought this is 20 years ago, this is something, you know, homeopathic, I would say, and why should it work actually? And we smiled at the doctors, at the experienced doctors that gave it to their patients for several years, because the mechanisms were not understood actually, you know, and as the name suggests, it's been thought initially, I believe, that you somehow do a vaccination against the bacteria if you give it, and then in the last, I would say, 20 years, it's been more and more understood. But some of these studies, and that's also what you see if you look into the different effect sizes between the systematic reviews and meta-analysis, some of these studies were done including only very few patients, were done without describing exactly the methods and so on. And so I know from huge discussions also in advisory boards and so on that there was some skepticism whether the evidence is good enough or not. And now I believe in the last 10 years, there were very good papers of good quality, good studies that came up showing that the evidence is very good. The reason I'm saying I believe there should be more studies, especially including a variety of different severities, is that to me it's still unclear whether we should give it only to patients that had, let's say, as in one of these studies, at least 6 RTIs documented in the last year, or whether it could even be beneficial for all children, you know, healthy unselected infants. Why shouldn't we give it to all of them? And that's why I'm saying I believe there should be more studies, not necessarily to replicate what has been done, because the evidence for this is good, but to better understand, is there a, I don't know, is there a certain population that does not at all profit, and where it would not make sense to give it to them, although there's no harm, I have to say.
Well, thanks very much. I think I certainly don't disagree with what you're saying. I think it's very sound thinking. Stefania Ballerini has put a couple of questions up, and I think you'd be probably the right person to respond to that, if that's okay, Philip.
So the one question is, can you expect a resurgence of RTIs, in particular lower respiratory tract infections in preschoolers after the reduction in the COVID pandemic? Yes, I would say yes. We see it already. We have discussed briefly before that in Australia, you have seen it half a year ago. And we in Europe see now in May, June, RSV hospitalizations and resurgence of at least RSV. And I think the rhinovirus did not disappear that much as the RSV anyway. So I would say yes, we would expect a resurgence of RTIs after reduction in COVID pandemic. And the second question is, could we use safely the product as complementary therapy to vaccines? I would say yes, of course.
Well, we've started talking about developing asthma vaccines, which would be agents to modulate the immune system away from unwanted problems. I'm not sure that it sort of fits the definition of vaccine to a degree. Deborah.
Yeah, that'll be an interesting question to answer. I mean, vaccines now, as we learn more about immune training, many vaccines have got off-target effects via immune training. So how those mechanisms will intersect will be very different. But I imagine similar mechanisms they may very well, if a vaccine doesn't have off-target effects, improve how the vaccine works. But there's also the area of things like immunotherapy for atopic diseases. It could potentially be a very good adjuvant for multiple types of immune-based therapies, I think.
Well, we've just come up over time, and I'm sure we could spend the next hour talking about all the implications of this, because there are a lot, and about the potential importance of using immunomodulation to train the immune system to behave in a way that is more acceptable for our hospital admissions and for our reducing wheeze and asthma in particular. And I'd like to thank Philip and Deborah very much for your contributions, and to pharma for hosting this seminar. I hope the audience has found it as interesting as we have, and thank you very much.
Thank you.